In the previous video, you got a good sense of how the male and female reproductive systems work. As you've seen, there are lots of moving parts, and they must work together in concert for reproduction to occur. Timing is everything. In this video, we'll delve into the hormones that drive it all. What we'll see is that there isn't just one conductor of the symphony who oversees everything. Rather, our hormonal system is an intricate and delicate set of feedback loops that together drive our reproductive biology. Our hormonal system is more formally called the endocrine system, or endocrine system. It consists of multiple glands that secrete molecular triggers. The molecular triggers, called hormones, stimulate specific tissues to do specific things at specific points in time. Hormones are secreted into the blood and through the blood travel around the body and influence the actions of various organs. The organs respond differentially, depending on the receptors they have. Are the receptors on the cells particularly sensitive or particularly resistant to the molecular trigger? Organs and tissues differ from each other, and so hormones will affect different parts of the body differently. Hormones were first identified by Western scientists in 1905. Our increasing understanding of what hormones do has led to enormous improvements in human health, including contraception and overcoming infertility. Tremendous research effort has been and continues to be aimed at understanding hormones and also the receptors on cells for receiving and responding to those chemical messages. When it comes to the hormones involved in human reproduction, we are going to focus on the hormones produced in the gonads, the ovaries and the testes, and the pituitary gland in the brain. There are about 50 different hormones. We'll just focus on 6 of them, as they are the major players in human reproduction. One key point to know here is that all of the hormones we are talking about are found in males and females, but there are big differences in the timing and the degree of their expression. The first 2 that we'll talk about are estradiol, which is a form of estrogen, progesterone, and testosterone. All 3 of these are produced in the gonads. Estradiol and progesterone are produced by the ovaries in females. But these aren't the only tissues that lead to the production of estrogen. Cells in the adrenal glands, which are located just atop each kidney, and cells in the testicles and adipose tissue produce an enzyme that converts testosterone to estrogen. This is how males also have estrogen in their bodies, despite not having ovaries. And this is why higher levels of adiposity influence the level of hormones in the body. Adipose tissue plays a role in the endocrine system. One thing to keep in mind here is that males and females both need estrogen to be healthy. Now, on to progesterone. Progesterone is a steroid produced in the adrenal gland, again, the one near the kidney, as well as in the gonads, ovaries, and testes. Now remember, when I mentioned that the corpus luteum, the follicular structure that nurtured the maturation of the egg cell, when I introduced you first to the corpus luteum, I mentioned that this post-ovulation structure plays an important role in the ovulatory cycle because of the hormone it produces. That hormone is progesterone, and it is essential to keeping the uterine lining for keeping the uterine lining in place during the luteal phase of the ovulatory cycle, and when an embryo has implanted in the uterus. Now, progesterone is so important that the HCG, the hormone produced by the implanted embryo, it induces the corpus luteum to keep producing progesterone, and thereby keeps the uterine lining from being shed through menstruation. Eventually, the embryo develops its placenta, which then produces progesterone, taking over that job from the corpus luteum around 10 weeks into the pregnancy, or about 8 weeks after fertilization. they count pregnancies in kind of funny ways. So, so 10 weeks into the pregnancy in the way the medical profession would call it. So testosterone is produced by the testes and also by the ovaries. And so again, males and females both have this hormone and both need it to be healthy. You have likely heard quite a bit about estrogen and testosterone, and possibly even progesterone before today. But you might be much less familiar with the next three hormones: the follicle-stimulating hormone, FSH, the luteinizing hormone, LH, and prolactin. These three hormones are produced in the pituitary gland, a pea-sized structure located almost in the very center of your head. LH and FSH do different things in males and females. In males, demonstrated in the diagram shown here, LH induces the Leydig cells in the testes to secrete testosterone. FSH also acts on the testes, stimulating maturation of the sperm cells. Since testosterone is constantly being produced and sperm are constantly being generated in males, FSH and LH are produced at a pretty constant level in human males. There isn't a lot of variation over days, months, or years, although they do dramatically increase during puberty when sexual maturation is occurring, and gradually lower as men age. Testosterone levels gradually reduce as men get older. There's a feedback loop between LH and testosterone. LH induces the production of testosterone, and testosterone suppresses the production of LH. This is how testosterone levels are balanced within the body. And keep in mind that that balance adjusts over the course of a man's lifetime. So there is a temporal dimension to hormonal changes in males, but nowhere near on the frequency of what we see in females during the ovulatory cycle. Now let's turn our attention to the role that these hormones play in the female reproductive cycle. This diagram should be familiar from the last video. It shows the changes in the ovary and in the uterine lining that occurs over the monthly ovulatory cycle. Remember, the follicular phase is the time before ovulation, and the luteal phase is the time after ovulation. Let's add the hormones to this figure. At the top part of this diagram, I've added a graph showing the relative levels of estradiol and progesterone throughout the cycle. Remember, these two hormones are produced by the ovary. This graph shows that estradiol gradually increases in the first part of the cycle and then spikes just before ovulation. Estradiol is important in this first phase of the cycle because the endometrium, the uterine lining, responds to the rising level of estradiol by increasing in thickness. As ovulation occurs, estradiol drops quickly. Now, just a quick note here. I mentioned this earlier, but to remind you, you may be more familiar with the term estrogen. Estradiol is a specific form of estrogen, but for the purposes of this class, you can use these terms interchangeably. Now, in contrast to estradiol, progesterone levels are very low at the start of the cycle. Progesterone starts to build right before ovulation. After ovulation, it then rises significantly and stays at a high level until the corpus luteum disintegrates. Progesterone level is correlated with the corpus luteum because it is, in fact, a causal relationship. The corpus luteum produces progesterone. The endometrium responds to this rising level of progesterone by adding a functional layer of mucosa and also by staying intact. But once the corpus luteum comes to an end and the progesterone drops, the endometrium is shed and a woman menstruates. Some women experience changes in mood, changes in how they are feeling over their ovulatory cycle. Part of this is thought to be connected to levels of progesterone. Recent research indicates that high levels of progesterone decrease the activity of the amygdala in the brain, and amygdala activity is tied to anxiety reactions. The more active the amygdala, the more anxiety one feels. High levels of progesterone lead to lower levels of amygdala activity and hence lower levels of anxiety. When progesterone drops precipitously at the end of the ovulatory cycle, this appears to be connected to the higher levels of anxiety that some women with premenstrual syndrome experience. Oh, two more interesting little factoids about progesterone. Progesterone increases body temperature, and it can decrease immunity. Whew, take a breath. That's a lot, isn't it? Now, let's add LH and FSH to this cycle. In this image, you can see that I added another graph to the top of the composite figure. This graph shows the relative levels of FSH and LH, two hormones produced in the anterior pituitary. Both FSH and LH stimulate maturation of the follicles and secretion of estrogen and progesterone in the ovary, but they also work together to trigger ovulation. Notice that estradiol spikes just before there is a little rise in FSH and a huge surge in LH. That estradiol spike triggers the LH and FSH spikes through another hormone, the gonadotropin-releasing hormone, but you don't need to worry about that one here. Now, you have a good overview of the hormonal changes that underlie the ovulatory cycle. Putting all of this together, we see that there are two phases of the ovulatory cycle, the follicular phase and the luteal phase, with ovulation marking the transition between them. The menses, when the uterine endometrium is shed, is technically considered part of the follicular phase. Now, you may have noticed that I keep referring to this as the ovulatory cycle rather than the period or a menstrual cycle. So, in many ways, the outer expression of all of this cycle are the menses, and so it kind of makes sense that many people would call this the menstrual cycle, but it's really all about ovulation. And so, biologically speaking, it's better to be called the ovulatory cycle. Now, one thing about the cycle is that the luteal phase of it tends to be pretty consistent in lasting about 4 days. But you'll remember from the last video, the ovulatory cycles typically range from 24 to maybe 36 days. Most of the variation in the ovulatory cycle, it actually comes during the follicular phase. So that's where most of the variation in cycle length comes from, not the luteal phase. Okay, take a deep breath. Yeah, it is a lot of information to give to you all at once. But now that you have a sense of this ovulatory cycle, you may have paused and asked yourself, what happens to these hormones when a fertilized egg gets involved? When an embryo implants in the uterus, it needs to start producing HCG in order to keep the corpus luteum alive and producing progesterone for another 8 weeks. This gives the embryo time to develop a placenta and then produce progesterone on its own. Progesterone is key to gestation, as you can tell by its name, progestation. This progestation goes from just a little boost during each luteal phase, when progesterone levels are about 25 milligrams per day, to more like 400 milligrams per day during pregnancy. Since progesterone suppresses maternal immunity, this is one of the reasons why pregnant women are at an increased risk of negative outcomes from infections. The immune system has to be suppressed because, remember, an embryo is basically a parasite living inside a woman's uterus. But after birth, when the placenta is born, along with the baby, the progesterone precipitously drops from about 400 mgs to 0. It is a kind of crazy ride, that dramatic of a shift in progesterone. From personal experience, I can tell you, when I gave birth to my daughter, No one had actually warned me about this, and did I do a lot of throwing up and crazy shivering. Progesterone withdrawal is intense. The womb is not the only place where hormones are doing amazing things during pregnancy. We are mammals, which means that during pregnancy, the mother's body is also preparing to produce milk for the coming baby. Mom's breasts start to prepare for milk production pretty soon after a pregnancy is established. This is why one of the early signs of pregnancy is breast enlargement. Alongside the breast changes are changes in the pituitary gland as well. The pituitary, the same gland that produces LH and FSH, it also produces a hormone called prolactin, and prolactin is the key to producing milk. During pregnancy, the pituitary doubles in size because of an increase in the number of cells that produce prolactin, but these cells are put into a holding pattern until after the baby is born because of progesterone. The high levels of progesterone being produced by the placenta suppresses prolactin. As soon as the placenta is shed from the mother's body as the afterbirth, so too goes those large doses of progesterone, and prolactin is free to do its thing. Milk is produced. Breastfeeding is a really amazing feedback loop. Those cells in the pituitary are triggered to produce prolactin when a woman's nipple is stimulated by suckling. Within 5 to 15 minutes, her prolactin levels will be 20 times higher, and then it diminishes just 10 to 30 minutes after suckling stops. So the more suckling, the more prolactin is produced, and the more milk mom's breasts are stimulated to produce. You can think of it as like baby's action of suckling is basically putting in an order for the next meal. This is why it is so important for nursing mothers to either be with their baby so they can nurse regularly and often, or for her to pump milk regularly and often. Without the regular stimulation, mom's body will stop producing prolactin and consequently stop producing milk. This is also how babies can gradually wean themselves. The less they suckle as they move on to other foods, the less milk there will be. This feedback loop is also why some women can produce milk for many years, such as women who work, or who did in the past, work as nursemaids. Once a woman's body starts to produce milk, as long as she is nursing, she will continue to produce milk. Oh, a couple of other interesting factoids about breastfeeding for you. 1. Prolactin suppresses the hormone that stimulates FSH and LH. This means that when prolactin levels are high, the ovulatory cycle won't start back up. Since prolactin is stimulated by suckling, the more suckling, the less likely FSH and LH will kick back into gear and ovulation will happen. But as bouts of nursing decrease, prolactin levels are more episodic, and FSH and LH will come back into action, and ovulation will begin again. That time when prolactin is suppressing FSH and LH, this is called lactational infecundability. Keep that mouthful of a word, of a term, in your mind, as we will talk about this again before the module is done. Oh, the second factoid I want to share. Suckling also stimulates oxytocin, which is sometimes referred to as the love drug. This means that it feels really nice to nurse. I mean, once you get over the physical challenges and have everything working smoothly, it feels really nice. There's this oxytocin surge that comes with breastfeeding. Leave it to evolution to have come up with a psychological reward for nursing one's baby, so mom will be enticed to nurse her young. Now that is a pretty big evolutionary advantage. Oh, and prolactin also changes how sleep is induced, so it is actually easier to go back into a deep sleep, which is very useful when you are getting up multiple times in the night to nurse. You now have a good sense of how these hormones underlie typical male and female reproduction. We've seen that both males and females have all of these hormones. And yes, males actually do also have prolactin, while men can theoretically be induced to produce milk if you stimulated their nipples enough. Though I definitely would not recommend trying this. The more common way men experience prolactin is because of its involvement in sexual arousal. Too low or too high levels of prolactin in a man leads to low sexual arousal. Kind of like a Goldilocks effect. You need just the right amount. So everyone has these hormones. Men typically have pretty stable levels, and women experience these in a cyclical fashion as they go through their ovulatory cycles and pregnancy. Such a complex system with lots of feedback loops. Knowing that there is variation in how much of a hormone a person's body is innately inclined to produce, as well as variation in the receptors on all the various types of cells in the body, it should come as no surprise that there is a lot of variation in human biology tied to variation in these hormones. We hinted at this before, as variation in the endocrine system underlies part of the variation in sexual determination and dimorphism that we discussed in Module 13. And there is another source of variation in hormones that we need to think about too. Endocrine disruptors. It turns out that there are chemicals in the environment that look so much like the hormones in our bodies that when they get into our bodies, they trick our cells into thinking that a hormone is there, giving instructions. We talked about these a little bit during Module 7 in the adiposity experience when we thought about obesogens. Now, we will meet the endocrine disruptors that mimic the key hormones involved in human reproduction. For this, proceed to the next video and meet my colleague, Professor Hayes.